بسم الله الرحمن الرحيم. طبعا احنا النهارده على لقاء مع الحلقه الثانيه من نيفروباثولوجي. انا يعني مش لاقي كلام اعبر بيه عن امتناني وشكر للدكتوره وسام، طبعا استاذه الباثولوجي جامعه بني سويف وممثل مصر في الاي اس ان كنيفروباثولوجي. والناس كلها الحلقه الاولانيه الفيدباك كان اكثر من رائع، وانا متاكد النهارده لانه النفرولوجي هو glomerulonephritis او glomerulopathy يعني في المقام الاول. فمش عاوز اخد من وقت الدكتوره وسام اكتر من كده، والمايك معاك يا دكتوره وسام، اتفضل.
متشكرة جدا دكتور حسين. يعني مجاملاتك دايما الحقيقة بت overwhelm يعني.
ربنا يخليك.
احنا بما ان احنا هنبتدي this part of our course by زي ما دكتور حسين قال glomerulonephritis او glomerulopathy. الأول we have to know what do we mean by glomerular pathology or how we interpret glomerular pathology. Okay. So let's start, in order to understand what we mean by glomerular pathology and what's glomerulonephritis, we need to have a basic look at the histology. This is how glomerulus look with a scanning electron microscopy. A scanning electron microscopy is a type of EM, which basically gives you a 3D picture. So you have an afferent arteriole, an efferent arteriole, and this is the glomerulus, which is basically a collection of capillary loops. I want you to imagine if we had a cut section through this with this scanning electron microscopy, and this is what you get. Now, this is the cut section in the glomerulus. This is a cartoon, of course, but it shows you that we have capillary lumina with red blood cells, and that these capillary lumina are lined by endothelium. This orange cell, sorry, the arrow is misplaced. This orange cell with this blue nucleus is the endothelial cell, and that this endothelium is actually fenestrated, as you can see here. It's like a sieve, أو زي مصفى ما بنقول. So this is the normal endothelium. So when we come to look at it by ultrastructural, by electron microscopy, this is, again, these are the podocytes, this is the glomerular basement membrane, and this is the endothelium with its fenestry. And we know, of course, that the endothelium plays an important role in the glomerular filtration barrier. Then we have the glomerular basement membrane, this red line, and we have what we call visceral epithelium, the blue cells. The visceral epithelium, or the podocytes, have these food processes, and these food processes, as you can see, are all lying over the glomerular basement membranes. They are interdigitating food processes, and this means that you can have a food process of one epithelial cell here, and this food process can belong to another podocyte with somewhere else in the glomerulus. Together, the podocytes, the basement membrane, and the endothelium forms what we know as glomerular filtration barrier. Between the food processes of the podocytes, we have what we call the slit diaphragm. This is an unseen, usually unseen barrier, and this is where most of the interactions of the molecules and the genetic makeup of the podocytes occurs. This is the slit diaphragm. Again, this is real life. This is electron microscopy. These are the podocytes, and even you can see here that they really look like feet. So these are food processes. You have the slit diaphragm in between. You have the glomerular basement membrane, a normal GBM, and you have the endothelium. Then finally, we have the mesangial cells, which anchors the capillary lumina together. And I want you to see that that there are some areas where the mesangium is in direct contact with the endothelium. So in some areas, the mesangium is separated by the glomerular basement membrane, but in other areas, the mesangium is in direct contact with the endothelium. And then all these capillary loops lies within the Bowman's space, and the Bowman's capsule is lined by the parietal epithelium, as you know, outside. So this is our normal glomerulus, and if we come to apply this on histology, this is silver stain, and again, I said silver stain stains basement membranes black, so you can see the glomerular basement membranes, you can see the podocytes, these very pale cells because they do not take the stain, and then the mesangium, normal mesangium is not very apparent. Also, mesangium is stained by black, so we have a mesangial area anchoring different capillary loops, as you can see here. This is a normal glomerulus, nice capillary basement membrane, open patent Lumina, no inflammatory cells. Endothelial cells are fine, hardly seen. And this is how a normal glomerulus would look like. By electron microscopy, this is a low power to show you again the structure we're talking about. So this is a capillary lumen, and it's lined by an endothelial cell. Then we have all of these structures you see outside are the food processes or the podocytes coming from an epithelial cell. And we have again capillary lumina anchored by a mesangial cell. Here is the mesangial, here is the capillary lumina, and here are the epithelial cells spreading over through their food processes. Okay, so glomerular injury. You know better than me. This is a bit basic, I know for you, but let's go through it quickly. That glomerular injury involves, could be primary, which can involve the kidney, or secondary. The important thing is that for years and years, we say we don't know the underlying cause of most glomerular diseases. However, it is clear that immune mechanisms underlie most forms of primary glomerulonephritis and many of the secondary ones as well. So if we took antibody-mediated injury as the prototype to understand what happens in the glomerular, then we know that we have circulating immune complexes, which we are going to deposit within the glomerulus, or we can have in situ immune complexes formation, like here and like this scenario. Now, if we have this in situ immune complexes targeted against an antigen in the glomerulus itself, you're going to have them all with this linear pattern arranged along the glomerular basement membrane. However, sometimes these in situ immune complexes form the immune complexes. The antigen deposits first, then the antibodies come and they form in situ, and again you get a granular pattern. Or you get circulating immune complexes, all of them depositing along the glomerular basement membrane. We have to understand that these pathways are not mutually exclusive and that you can get a combination of both during the mechanism. And because of this, this is what's responsible for the pattern we've discussed last time when we have a granular immunofluorescence or when we have a linear immunofluorescence pattern. So that's why linear is considered to be characteristic of anti-GBM deposits. So the position of antibodies as part of an immune-mediated disease is what causes what we call a glomerular response. And we take this as an example for glomerular injury, including those on non-immune basis. And this provided a rational template to understand the pathogenesis, the classification of the disease, and the clinical expression of glomerulonephritis, which we see. But more importantly, it's this glomerular response which determines the pathology which can be observed in the renal biopsy. So this immune-mediated glomerular injury would depend on so many things: antibody titer, rate of deposition, antibody isotypes, the antigenic target, the mediators which are activated. But for us, what would determine the glomerular response would be the localization of immune deposits within the glomerulus. So out of this point, we can classify patterns of glomerular injury arbitrarily according to the site of deposits of the immune complexes or the antibodies, taking this as an example for each pattern of injury. So within the glomerulus, again, this is our glomerulus. This is a capillary, this lined by endothelial cells, fenestrated as you see. This is our podocyte with its food processes. This is our mesangium and another capillary loops. So the options we have are that we have immune complexes in the subendothelial space between the endothelium, and this is going to include the glomerular basement membrane. Here is the deposit, so it's exposed to the GBM and the endothelium, or deposits in the subepithelial compartment, which is going to be basically in contact with the podocytes, or deposits in the mesangial area here, which again can affect the endothelium because, as I said, we have points where the mesangium is in direct contact with the endothelium. So it's either mesangial, subendothelial, or subepithelium, or you can have subendothelial and subepithelial, subendothelial and mesangial, and so on. So if we have subendothelial deposits, we get what we call an endothelial pattern of injury. What do we mean by an endothelial pattern of injury? It means that these subendothelial deposits are going to cause inflammation of the endothelial cells, influx of phagocytes, leading to cellular edema, proliferation and necrosis. These leukocytes are going to produce a lot of chemokines and leukocytes and lysosomal products, which is going to lead to cell death, what we see as fibrinoid necrosis. Eventually, it can disrupt the glomerular basement membrane and irritate the podocytes, both the visceral and the parietal, and leads to what we know as extracapillary proliferation or crescent formation. So an endothelial pattern of injury is going to give you an exudative proliferative glomerulonephritis plus or minus fibrinoid necrosis or minus crescents. What's going to determine this? It's going to determine the underlying pathogenesis or the underlying etiology of this endothelial pattern of injury. The important point to understand is that within this, this is a continuum of the same process. You can start by proliferation, you can have fibrinoid necrosis, and you can have crescents in any form of a proliferative or exudative glomerulonephritis. What are the known diseases we know with this pattern? Post-infectious glomerulonephritis, of course, anti-GBM, all the vasculated glomerulonephritis, including lupus, hemolytic uremic syndrome, a malignant hypertension patient, HCV, cryoglobulinemia, and membranoproliferative GN. So all of these known glomerulonephritis or diseases can cause this pattern of an exudative proliferative GN. What will our patient present with? Our patient would present with hematuria, impaired glomerular filtration rate, plus or minus nephrotic proteinuria, hypertension, and oliguria. So this is what we used to call nephrotic syndrome or nephrotic/nephrotic syndrome. So when you have a patient with these manifestations, then you need to consider that probably the underlying glomerular pathology includes something which is acute, proliferative, plus or minus these manifestations. So this is just what a proliferative GN looks like. This is crescents, and this is segmental fibrinoid necrosis. We're going to go through all of these again later. Then the second pattern of injury is what we call epithelial pattern of injury. And in this pattern, where we have the deposits in the subepithelial space. Now here we have no inflammation, but we have actually, again, MAC formation, which is strange, but we do have activation of complement, which leads to podocyte injury. So podocyte injury, this is the normal podocyte food process. Then effacement happens. This is what we call effacement. So it's not standing straight over the glomerular basement membrane anymore. It's lying parallel to the glomerular basement membrane. And then by time there is detachment of the podocytes and they fall into the urinary space. So you have no inflammatory response. What are the diseases we know of injury? Membranous, minimal change, FSGS, a collapsing GN, diabetes, amyloidosis, light chain nephropathy, lupus, and again, MPGN. So these patients are the patients which are going to present with either a full-blown nephrotic syndrome or nephrotic range proteinuria, depending again on the disease, which is on the underlying disease. This is membranous, this is minimal change, this is FSGS, and this is MPGN. The third pattern of injury is the mesangial pattern of injury. Now, this is a tricky pattern of injury. This is where you have mesangial deposits in the glomerulus. Now, mesangial deposits are not always isolated. As I said, since they are in direct contact with the glomerular basement membrane and with the endothelium, sometimes, and in some glomerulopathies or glomerulonephritis, you will see mesangial and subendothelial deposits, mesangial and subepithelial deposits, or even without deposits, you're going to see mesangial and affection of the endothelium with a more of a proliferative glomerulonephritis, or affection of the glomerular basement membrane, where you can get also a podocytopathy together with the mesangial deposits. Mesangial pattern of injury will cause mesangial matrix expansion and or mesangial cellular proliferation. This is a very important point. The mesangium is two parts. It's the matrix and the cells. So always one of them dominates over the other in different diseases. So it's always important to differentiate whether we have a cellular proliferation or a matrix increase or expansion by deposits, or both. We have a prominent cellular proliferation associated with matrix increase or expansion. Sometimes, as I said, you can get segmental crescents and Bowman's capsular adhesions. And as I explained, crescents are due to the endothelial injury which can occur. Examples of mesangial pattern of injury are IgA nephropathy, hypertensive nephrosclerosis, diabetes, amyloid, light chain nephropathy, fibrillary or immunoductoid nephropathy. So this is when we want to correlate the mesangial pattern of injury to diseases. So this is what we call mesangial proliferation. This is here you have mesangial cellular proliferation. You have a lot of nuclei in the mesangium and not a lot of matrix increase. On the other hand, in diabetes or a nodular sclerosis pattern, you have a lot of matrix, mesangial matrix increase, but very few nuclei, very limited cellularity. And this is amyloidosis, where you get no cellularity at all. Chronic glomerular injury. Now, transient injury can disappear with complete morphological and clinical recovery. You know this better than me, like a minimal change disease, like in resolving membranous GN, IgA, or if we manage to treat the underlying disease. However, unfortunately, most of GN can undergo chronic and progressive glomerulopathy, where you can get capillary collapse, fibrous adhesions to Bowman's capsule, increase in mesangial matrix and cellularity, and accumulation of macrophages. So you can get this pattern, which is classic of focal segmental glomerulosclerosis, as we can discuss later. And this is, of course, very advanced global glomerulosclerosis. So because classifications are important, and in nephrology, classifications are mainly based on renal biopsy examination, hoping for standard histological criteria. But these classifications are not only for pathologists. The value for classifications are to unify the nomenclature, as we've explained before, but more important is to implement diagnostic information with prognostic indication and to facilitate clinical management. One of the most confusing subjects in the medical curriculum is actually the classification of glomerulonephritis. Glomerulonephritis is a complicated classification and a very confusing terminology. Let's start by terminology. Now, usually glomerulonephritis is either diffuse or focal. Diffuse means that you have a disease affecting all or more than 50% of glomeruli, while focal affects less than 50% of the glomeruli. The cutoff of the 50% has absolutely no evidence base. It's just an easy number for us to deal with. Within the glomerulus itself, the affection could be either global, that means it can affect all the glomerulus, or segmental, meaning that it affects only part of the glomerulus. The problem with the terminology of glomerulonephritis is that we have different names for the same thing. Minimal change nephrotic syndrome is minimal change disease, is what we used to call lipoid nephrosis, is what pediatricians call idiopathic nephrotic syndrome, is what some call minimal change glomerulonephritis. Please try to unify what we call the diseases. The recent literature is moving towards unifying the names we use for different glomerulonephritis, and the most accepted term now is minimal change disease. Glomerulonephritis is not accepted because actually it's not inflammation. Idiopathic nephrotic syndrome is a clinical term. Lipoid nephrosis is very old. Minimal change nephrotic syndrome, okay, if you want to call it this way, but the name is minimal change disease. Another glomerulonephritis, which causes a lot of confusion between nephrologists and pathologists as well, I have to say, is membranoproliferative glomerulonephritis. Membranoproliferative glomerulonephritis is mesangiocapillary glomerulonephritis, used to call lobular glomerulonephritis. There is no difference, and MPGN is mesangiocapillary GN. Mesangiocapillary GN is a very old term, not used anymore. Now, for years now, we've only been referring to it as membranoproliferative GN or MPGN, but some still use it, so you would know that mesangiocapillary GN is membranoproliferative GN. I hope we stop using it in order to limit the confusion and try to make it more clear for young nephrologists and pathologists. However, we have similar names, which does not mean the same thing. Mesangial proliferative GN is not focal proliferative GN, and it's not a membranoproliferative GN. And I've put this slide on purpose because there is nothing called mesangial proliferative glomerulonephritis. This entity doesn't exist in medicine and in nephrology. It's a mesangial proliferation, full stop. There is no GN we know of, which is known as mesangial proliferative. And I'm going to discuss this later again. However, notice the terms. When we mention mesangium, it means that the problem is in the mesangium. When we say membrane, it means that the problem is in the membrane together with proliferation. So don't mix up the terminology. And if you get a diagnosis of a mesangial proliferative GN, it does not mean MPGN and not the other way around. GN or glomerulonephritis is classified by different mechanisms. It's classified according to clinical, so we say rapidly progressive GN. We classify it according to etiology, so it's a post-infectious GN. We classify it according to immune mechanisms, so it's a lupus glomerulonephritis, but the main classification is via histopathology. And the important point to understand in histopathology that these are patterns established on light microscopy. Membranous, MPGN, focal segmental glomerulosclerosis. These are patterns and are not diseases. So this is the first very important point you have always to remember. So what we see on light microscopy alone is a pattern, not a disease. What do we mean by this? If we have thick capillary walls without hypercellularity or any form of mesangial expansion, then this could be membranous glomerulopathy, primary or secondary, thrombotic microangiopathy with expanded subendothelial zone, could be a fibrillary glomerulonephritis, which is prominently basement membrane, or could be light chain disease, again with predominance of capillary wall deposits. So not every thickened capillary basement membrane on light microscopy, just by light microscopy, without immuno, without EM, is a membranous glomerulonephritis. This is what we call membranous pattern of injury. Yes, 60% it will be membranous, but then you still have 40% that it can be anything else. You need immuno, and if you have diffuse IgG deposits then and C3, then this is membranous. If it's negative and you look carefully and you find endothelial swelling and expansion of the subendothelial space, then this is a TMA. If you do Kappa and Lambda, if everything else is negative, then you might figure out that this is actually a light chain nephropathy. What if we have these thick capillary basement membranes, but with mesangial expansion, but no hypercellularity? Then the options are that we can have an early diabetic glomerulosclerosis, which is diffuse, not nodular. We can have a secondary membranous glomerulopathy with mesangial immune deposits. It can be early amyloidosis. Again, it can be light chain disease. Again, it's fibrillary, or it can be a dense deposit disease. So look at this glomerulus. It has thick capillary basement membranes and mesangial expansion. Again, look at this. You have mesangial expansion and thick capillary basement membranes. And guess what? This is amyloidosis. So not always amyloid is going to give you this classic picture of this largely expanded mesangium. Again, here we have thick capillary basement membranes, expanded here, as you can see, and we have expanded mesangium. We have a minimal cellularity. This could be diabetes, this could be light chain disease, it could be anything. Now, this is an expanded mesangium with absolutely no cellularity, could be fibrillary GN or an immunotactoid, as you can see by EM. We can have focal segmental glomerulosclerosis without hypercellularity, as we're going to discuss later. This could be FSGS, a chronic sclerotic phase of a focal glomerulonephritis, or could be Alport syndrome. We can have mesangial hypercellularity. Now, this is what's usually called mesangial proliferative glomerulonephritis. As I said, this entity doesn't exist. Mesangial hypercellularity can be seen in minimal change. It's accepted with mesangial proliferation. It can be seen within the context of FSGS, even if it's unrepresented in the biopsy. So you can have mesangial proliferation, but there is a focal segmental lesion which did not show up in the biopsy, a sample problem. You need immuno whenever you see mesangial proliferation. This is a must. because it can be lupus glomerulonephritis class 2, it can be IgA nephropathy, it can be a resolving post-infectious glomerulonephritis, it can be C1q nephropathy, and this is just part of the list of what mesangial hypercellularity can mean. So as you can see, we don't have a primary or an idiopathic mesangial proliferative glomerulonephritis. This doesn't exist. So any mesangial form of hypercellularity or anything which some pathologists call mesangial proliferative glomerulonephritis is not a GN. You have to have further studies to know exactly which disease your patient has. And it can be dense deposit disease, of course. So this is again mesangial hypercellularity and mesangial hypercellularity. So by immuno, you can see that the deposits are mainly localized in the mesangium. Whatever these deposits are, they can be IgA, they can be only C3, so you can have a C3GN, they can be IgA, IgG, C3, so it can be lupus, can be IgA nephropathy, and so on. If we have both mesangial and endocapillary hypercellularity, that means also the endothelium is hypercellular. This can be, again, a form of a focal or a diffuse IgA or any form of mesangial proliferation. Endocapillary proliferative GN, diffuse proliferative post-infectious GN. It could be an early phase of an MPGN, and it could be thrombotic microangiopathy. So look at this. And now we have a lot of capillary hypercellularity, a lot of cells obliterating all of these capillary lumina, and we have segmental thickening of the capillary basement membranes. Now this glomerulus, honestly, can be anything. It can be lupus, it can be TMA, it can be MPGN, it can be IgA. So the differential diagnosis is wide. So this is only a pattern. This is what we're seeing. It's not a disease yet. You can have a segmental, only a segmental proliferation. Again, this could be vasculitis, could be infection, could be lupus. Extracapillary hypercellularity, crescents. Now, crescents could be a more specific pattern at light microscopy, but not always, because crescents are not that much readily identified. They're not so easy to diagnose as you think, except in full-blown cases like ANCA, for example. Sorry, or in a crescentic GN. However, you can see here, this is a crescent. This is a full-blown crescent, and this is what's left of the glomerulus. But this is collapsing glomerulopathy of FSGS. And I'm going to cover in the second talk the differences between them. Then we have a membranoproliferative, or what we call a lobular or a nodular pattern. So this is getting more chronic. So it can be MPGN, can be diabetic glomerulosclerosis, can be again MIDD or light chain disease, TMA again, fibrillary, immunotactoid, and so on. This is a typical nodular sclerosis pattern, as you can see here, whether this is light chain disease, diabetes, fibrillary glomerulonephritis, idiopathic, whatsoever. And then we have the advanced diffuse global glomerulosclerosis. Now, we have a problem that pathologists usually try to do their best in a biopsy to try to figure out an etiology or try to help the nephrologist, especially when they get these type of biopsies. But please don't, because you can do more harm than benefit. If it's end stage, if you have diffuse global glomerulosclerosis, if you cannot make up your mind with what is the problem with this patient, then don't. Then just write it down as global glomerulosclerosis, because I see a lot of these interpreted as fibrous crescents when this doesn't exist. And a lot of, as we're going to say in the FSGS, again, interpreted as focal segmental glomerulosclerosis. So don't do an effort with the globally sclerosed glomerulus. You cannot really get any information out of it. Advanced diffuse global glomerulosclerosis does not always mean that you have a glomerular lesion. It can be an end-stage glomerular disease, or an end-stage vascular disease, or an end-stage tubulointerstitial disease. Sometimes we can locate the primary compartment of the disease. So sometimes you can say, yeah, this is global glomerulosclerosis, but it looks like a primary tubulointerstitial disease, or it looks like a primary glomerular disease. But other times we can't. If it's end stage, it's end stage. And this is all the information you can get off. That's why we say timing of the renal biopsy is really important. Don't wait. So because of this, of all what we've been discussing, and because that these are patterns and not diseases, we needed to work more on the way we view these patterns under light microscopy or on the pathology, how we classify the pathological lesions. So through this course, I'm going to show you, and we're going to move from the past classifications, which were pure morphological classification, dependent only on the pattern of glomerular injury, into a more relevant classifications which we are using now in the present, which are based more on etiology and pathogenesis, which are mainly utilizing immuno studies, whether immunofluorescence or immunohistochemistry, rather than just pure morphology by light microscopy and electron microscopy, and hoping that one day we're going to discuss the future, which everybody is moving into gene expression profiles. So in a step towards this, towards new guidelines in glomerulonephritis classification, there was a consensus meeting a few years back in Mayo Clinic under the auspices of Renal Pathology Society to try to standardize how pathologists report classification, diagnosis, and reporting of glomerulonephritis. So this manuscript has basically suggested that classification of GN on the basis of etiology and pathogenesis is the way we should approach glomerulonephritis. And it makes sense. So we diagnose primarily on the basis of the findings by immunofluorescence microscopy or immunohistochemistry. And we integrate this with light microscopy and electron microscopy. So as I said, we're moving into the pathogenesis era because this is what dictates our management and treatment of the patients. And hence, we're moving into the era of utilizing immuno studies because we need to know which antibodies are involved within this glomerulonephritis, rather than the era of just relying on light microscopy or electron microscopy. This manuscript does not extend to other forms of glomerular diseases, which really does not, the pathogenesis is unknown, does not have immune complexes like podocytopathies and thrombotic microangiopathies. They have dropped the membranous in the beginning, and the slides are a bit old. However, it's included now because membranous is, of course, a glomerulonephritis. So on the basis of etiology pathogenesis, they have characterized 5 pathogenic types, each with specific disease entities. Number 1 is immune complex GN, polyimmune GN. 3 is an anti-GBM because this has a special pathogenesis. Then monoclonal immunoglobulin glomerulonephritis by immune clonal deposits, and C3 glomerulonephritis. So we either have an immune complex mediated glomerulonephritis, or no immune complex mediated glomerulonephritis like in polyimmune, or we have a specific antigen like anti-glomerular basement membrane, or we have the glomerulonephritis with an underlying mechanisms by monoclonal deposits, which are kappa and lambda, or it's a complement mediated disease like in C3 glomerulonephritis or glomerulopathy. Through this approach, then you know which line or which target of management you can have with which the target of your management with your patient. This is the basic format of kidney biopsy report they suggested, with the primary diagnosis mentioning the pathogenic type, the disease. Is this an IgA nephropathy, a lupus, an ANCA? Mentioning the pattern, because the pattern makes a difference. Whether this is mesangial proliferation, MPGN is different than when you have a necrotizing presentic pattern or when you have a sclerosing pattern, because this makes a difference in the prognosis of your patient. If we have a scoring or grading system like in IgA nephropathy or in lupus, it should be applied. And then any additional features, and the additional features are very important because these are the prognostic features. The degree of global glomerulosclerosis, extent of interstitial fibrosis. This is mainly what we've discussed last time. I'm just going through it. And they have suggested if we have clinical data to be also included in the diagnostic line. And if you have other diagnoses. Let me give you an example. So let's say we have a hepatitis C associated immune complex glomerulonephritis. So now the pathologist knows that the patient is HCV positive and he's not treated. So the primary diagnosis is an immune complex glomerulonephritis. The pattern of injury is a membranoproliferative glomerulonephritis, and additional features will be that it has prioglobinemic GN. This is hepatitis C associated. This patient has focal global glomerulosclerosis, moderate tubular atrophy and interstitial fibrosis, moderate arteriosclerosis, and so on. Lupus. Let's say a patient with lupus nephritis has lupus nephritis and thrombotic microangiopathy. Now, both of them are important. So both of them are added within the primary diagnosis because both of them is contributing to the clinical picture of the patient and the cause of the biopsy. And then you put the rest. However, let's say we have an infection-related GN, which is superimposed on diabetic nephropathy. Then the basic diagnosis or the main problem of the patient is that he has an IgA dominant infection, and this is superimposed on pre-existing diabetic nephropathy. Anyhow, this is just to give you an example of what they meant by primary diagnoses or secondary diagnoses. Doesn't make a difference as long as you understand the diagnostic line and what your pathologists write. Few years later, they have made another proposal for standardizing grading of chronic changes in native kidney biopsy specimens. Now, what they did was just basically that they used what we've been using all the time with the regular scoring systems, whether in transplantation, whether in lupus, whether in IgA, diabetes, whatever classification and scoring system we have in renal pathology, we follow the same lines in scoring chronic lesions. So none of this is new. They have just suggested that these scores should be applied in all reports, which actually most of us do. So the score is basically for you to know how we score. So 0 is that you have less than 10% glomerulosclerosis, less than 10% interstitial fibrosis, less than 10% tubular atrophy, or you have arteriosclerosis, entemal thickening, less than 10% thickness of the median. Entemal thickening is less than the thickness of the median. Now, 1, 2, 3 depends on the percentage. So 10 to 25%, this is the number of glomeruli which are globally sclerosed. Here, this is the percentage of interstitial fibrosis and tubular atrophy within the biopsy you provided. So up to 25%, it's 1, 26 to 50, it's 2, 3 is more than 50%, and arteriosclerosis, it's either 0 or 1, entemal thickening, if the entima is thickened more than the thickness of the media. This is an easier way actually of scoring arteriosclerosis. And they have suggested a total chronicity score to be added to the biopsy by addition of all the scores. So if you have a biopsy with a score between 2 and 4, you have mild chronic changes in the biopsy. But if you have a biopsy with a score which equals 2 or more than 8, then this is end stage. So let us test your capability and see if we have digested what's been said. Okay, I'm going to explain, or I'm going to tell you what's in the picture. What's in the picture is a normal glomerulus. This is a very normal glomerulus. And then we are going to see, again, this is a normal glomerulus by PAS. Very nice thin capillary basement membranes, very limited mesangium, very nice podocytes, nothing, no inflammation, no endothelial cells, absolutely nothing. So this is a normal glomerulus. Okay, so if I told you that this glomerulus comes from an 11-year-old boy who presented with lower limb edema, toughness of eyelids, protein creatinine ratio of 4 grams, and a serum albumin of 2.8 and bland urine sediment, and his immunohistochemistry was negative. What's your diagnosis?
Dr. Al-Hadidi? Dr. Muhammad Hadid.
I think that my diagnosis will be towards the minimal change disease, since the light microscopy showed nearly no change. I can see that the mesangium is not expanded, the GBM is not thickened. So I'm more towards the minimal change based on the clinical data and the histopathological picture.
Excellent.
And the same answer came here in the chat from Dr. Wala and others.
Okay.
Okay.
Now we have the same picture and the same patient. Okay? So the same patient and the same picture, but with the addition that this patient is steroid resistant, and in the pathology, we found some interstitial fibrosis, and he has a family history of renal disease. So we still have the same glomerulus and the same patients with the same clinical data, but just extra info. They're steroid resistant, and we have some mild interstitial fibrosis, which should not be accepted in an 11-year-old boy. I can accept it if he's a bit older, but not in a child. He did not live long to have any form of interstitial fibrosis, and family history of renal disease. So
a lot of answers from the chat. Six candidates referred to maybe FSGS.
All right, I agree. So maybe unsampled FSGS, it was not represented in biopsy. So this is something important for you to look at the report. If you have a patient like this, and if you see that the number of glomeruli is not enough, and that this child has a bit of mild interstitial fibrosis, which shouldn't be there, and you know he has a family history, then consider this. You need to consider afterwards. Don't forget it. He's steroid resistant. So the boy could also be Alport. The same picture. So it's the same glomerulus. So now we have a 37-year-old male who presented with lower limb edema, roughness of eyelids, a protein creatinine ratio of 4.5 grams, and urine red blood cells 10 to 15. Again, associated with mild interstitial fibrosis and mild arteriolar thickening. What do you think? Is that enough? Light microscopy. Is light microscopy enough?
Can we know more from the immunofluorescence?
Now, I only have a light microscopy. Tell me, what's your differential diagnosis?
My differential diagnosis would be maybe unsampled FSGS.
Okay.
It might be minimal change disease.
Okay.
Yes, it has a low incidence in this age, but could be secondary to any other drug or malignancy.
So why do you need the immuno if you think that this is the FSGS or minimal change? If this is your differential diagnosis, why do you need the immuno?
This is my differential diagnosis based on that I have no idea about the immunofluorescence. I want to know more about the
You put a differential diagnosis based on this pattern, and then we can see what we do with the immuno or with any other study you want. Okay. So tell me,
Dr. Wesam, just a moment. Some of the answers came to the chat saying membranous. I think it is not membranous. And the others saying if immunofluorescence is positive, then it will add to the differential diagnosis of immune complex mediated or something like that.
This is a pattern of normal. This is a normal glomerulus. This is still our glomerulus, which we've been going through with the same guy. But let us see. If we looked carefully and we found some or minimal mesangial expansion, you need first to do Congo-Red. This is the first differential diagnosis of minimal change or of a no change under light microscopy in an adult, because early amyloidosis is really very difficult to detect. So this is number one you need to do. Number two is that yes, you need to do immuno because early membranous looks like a normal glomerulus and it can only be detected by immuno. So this is your second differential diagnosis. And if with the same glomerulus, but this time it's a female who has a lower limb edema, arthritis, protein creatinine ratio of 1.2 grams, and microscopic hematuria, then, and don't tell me immune profile, these are the information we get. So interpret like us. Again, it's still our normal glomerulus. Fine. Then this is why you get a report saying that this type of biopsy needs immuno. It needs further studies. Can you really build a diagnosis? Your patient is coming protein creatinine ratio of 1.2.
No, I can't.
Hematuria. Can you, on this pattern, this is what we have on the biopsy, can you put a diagnosis which fits into this clinical picture?
This could be an early lesion of anything, but based on the patient is that she's female and she has a young age. It could
yes,
be...
but then you have a pattern of no change, right?
Yeah. Yes.
Yeah. which usually is interpreted as minimal change disease or unsampled FSGS. Again, you have to do, yes, I know the protein create ratio is very low, but again, Congo red is a must because of the microscopic hematuria, and immuno is a must. And this patient had mesangial IgG, IgA, and C3. So she was GN, but she could also be IgA nephropathy. Don't forget this.
They add lupus as well, Dr. Wesam.
Yes, this is what I said. She was first +1 lupus, but she could also be IgA because you can get a codominant, as we're going to discuss in IgA, inshallah. So, no abnormality by light microscopy.
دكتور محمود تعال بص.
That you could have an option. It's an option which never crosses your mind. Or that you can have glomerular disease with no light microscopic changes, like minimal change glomerulopathy, or a thin basement membrane nephropathy, for example, if the patient is only hematuric. Or, as Mohammed have said, we can have a mild or early glomerular disease like lupus nephritis, IgA nephropathy, C1q, membranous, amyloidosis, Alports, etc. So I was just trying to give you an example of what we mean by pattern and what's the difference between a light microscopy pattern and when does it become a disease. It becomes a disease together with the clinical data you provide and with the extra studies we do. Do you know where this is? Anybody knows where this is?
In C9? In Dahab?
It's in Sharm el-Sheikh. So, yes. The art of diagnostics is to know your landscape and to find the decisive indicators even when it's partly cloudy, and this is what pathologists do. But remember that pathology does not always give the final answer. It's interpretation, so interpretation has to be discussed, amended, modified, and as you guys, we are also entitled to misdiagnosis and mistakes sometimes. Okay, now we're going to move. I'm going to take, if we can take a few questions before we move on.
Yes, please.
To the FSGS and minimal change. Okay.
And if anyone has any question, please raise your hand. أي واحد عنده سؤال يرفع إيده. دكتور محمد شيل الخط الأحمر اللي موجود في السلايد. أي سؤال؟
مفيش أسئلة خالص؟
هو أنا عندي سؤال.
اتفضل.
يعني كده based on the last case you showed us إن المفروض إن لو في early lesion أنا أعمل كونجو ريد أو ممكن أخلي كونجو ريد عندي كروتين ستين في كل البايوبسيز اللي تجيلي، ولا ده في حالة إن اللايت مايكروسكوبي مش مديني الصورة كافية؟ يعني لو اللايت مايكروسكوبي مثلا في تيكن بيزد برين في ميزانجيال اكسبانشن، هل انا كده استغني عن الكونجرين لان الحاله ما كانش فيها بيكتشر شظيصه انها تبقى اميلويدويد، ولا انا استخدم
That's why we recommend that we do routine Congo red, because it's not always suggestive, and you need a very experienced pathologist and a very trained eye to really be able to always detect it on a light microscopy.
In the last session, Muhammad, I asked Dr. Wesam, is it routine to do Congo red for all cases? And she answered yes. She incorporated Congo red as a routine because early amyloid can be only picked by this way.
And masked amyloid. And
yes.
Inshallah, when we come to amyloidosis, you're going to see examples and the importance of why we should have a routine Congo red examination. Okay, let's continue.
Yes, please.
Minimal change disease and FSGS. This is the case of the swollen child. He was a 7-year-old boy who developed rapid weight gain, increasing edema, face was also bloated. He had his breathing was comfortable, but his serum was milky, presence of excessive albumin in the urine. And this was the first case of minimal change in 1954. This is the child at presentation, and this is his old photograph, and this is how a general practitioner have explained the problems that this child has. So the classic nephrotic syndrome, as you know it, much better than me. And this is just to show you the oil red fat stain, which shows tubular epithelial cells, which are filled with resorptive lipid, of oval fat bodies, which used to be described in the urine. All of this orange is the fat within the tubular epithelial cells, and these are the free fat droplets and the oval fat bodies they used to diagnose by Sudan 3 nephrotic syndrome by it. Minimal change disease, I don't have much to say about it because it's really a straightforward disease from the pathology point of view. It has an acute onset nephrotic syndrome, and this is something we always need to remember. If we can have an acute nephrotic syndrome, then minimal change is going to be one of its causes. It's commonest in children, of course, as you all know, but it can occur at any age, and that 80 to 90% of it are steroid responsive. Morphology, glomeruli are normal by light microscopy, by immunohistochemistry. Sometimes you can get mesangial IgM, the causes behind what was named IgM nephropathy. This is allowed within the minimal change context. It doesn't worry me, just IgM, no C3. So, because as we said, IgM is a macromolecule and can be non-specifically tracked. And by EM, you get diffuse effacement of the podocytes. Let me remind you, again, this is our normal glomerular basement membrane. These are our podocytes. These are our endothelium. Here is the glomerular basement membrane. You cannot see these nice, cute food processes anymore. They are just all effaced and with continuum and of continuum. The differential diagnosis, as we just discussed, early stage 1 membranous, unsampled or unrepresented FSGS or amyloid. This is a 25-year-old woman who presented when she was 13 weeks pregnant with sudden onset nephrotic syndrome and hematuria. She presented with edema, periorbital and legs, and was found to have proteinuria hematuria. She was treated first by antibiotics before referral, but she developed lumbar pain and was referred to a nephrologist. Upon admission, she had progressive edema, no fever, no family history of renal disease. Her serum creatinine was slightly elevated. I don't know how much was it, but her clearance was 50 mils per minute. Serum albumin, this is a typo, sorry, it's not 9. Urine was 15 grams. I think this was 0.9, 15 gram protein per liter. She had some erythrocytes and some red blood costs. So a renal biopsy was performed. What's your differential diagnosis? Quickly.
Dr. Hariri?
Which one of these?
Which one? I think we will go more towards the FSGS or
What is membranous and lupus, Dr. Wesam? Because in pregnant lady, GFR of 50 milli per minute is marked reduction.
But she was immunologically negative. She was not lupus. That's why I didn't include it. But membranous, yes, of course, you're completely right. Membranous is also, it actually should be number 1.
Yes. And as well, so long as I don't know the immunology, I put lupus in the differential diagnosis because GFR 50 is marked reduction of the GFR in pregnant lady.
Yes. Okay. That's her biopsy. And you can see that she has a normal glomerulus, our normal glomerulus. These glomeruli were also normal. She has just slight synecdoche, just slight adhesions to the Bowman's capsule, but nothing in the biopsy. Again, you can see no sclerosis, no inflammation, absolutely nothing. Her immuno was completely negative. And her EM, as you can see, she had diffuse effacement of the podocytes, yes, and the glomerular basement membrane was clean. No immune complex deposits. The podocytes had massive injury with this microvillus cytoplasmic transformation, which usually accompanies podocyte injury. These little things you see here. So she was diagnosed as a minimal change disease. She responded well to high-dose steroids, and urinary protein loss disappeared within 6 weeks. But 2 years later, she came again. and she relapsed with massive proteinuria again, 12 grams per day. After 1 week of steroids, a renal biopsy was performed. What do you think now? Is it something else? Or did she has minimal change again? Or what would be?
Maybe
Yes.
minimal change, maybe FSGS, maybe the lupus podocytopathy. So I repeat again and again the immunology profile for this
Yes,
case.
no, yes, the immunology profile is negative.
So,
She's
okay.
not.
So maybe minimal change or FSGS or membranous.
Membranous, she wasn't membranous, but maybe she developed membranous later on.
I know.
That's also an option. However, what I would think is that she is FSGS. Now we saw her glomeruli again, and again the same delicate capsular adhesions, which we've seen before, but look here. She has a classic segmental hyalinosis related to the tip, and her immuno showed this IgM again at the tip and C3 at the tip. So her final diagnosis,
FSGS, focal segmental glomerulosclerosis tip lesion, yes.
Tip lesion. So minimal change disease and FSGS concept of podocytopathies. Diseases of the podocytes results in structural and functional abnormalities that lead to disruption of the glomerular permeability barrier and subsequent proteinuria. A variety of conditions with abnormal podocyte function can lead to this, like genetic abnormalities, viral infections, inflammatory injury, hemodynamic alterations, abnormal signaling, and basement membrane changes. So there was a school, an old school, which used to say that actually minimal change disease and FSGS are the same continuum. This was a lot of years ago. I'm not going to tell you how much, but it was when I was training. So this school used to say that minimal change and FSGS are just the continuum of the same disease passing through mesangial proliferation. Others said no, that they are completely different diseases, whether the minimal change and FSGS. I think the variety, as we're going to discuss here, depends on which type of FSGS are we discussing. However, when we discovered podocytopathies, I think that we know that this is really a spectrum of the same disease. Podocyte injury can lead to no change in podocyte number, and then this will lead to minimal changes on histology, what we see as minimal change disease, or can lead to podocyte detachment and death, and this is where we see segmental sclerosis or FSGS, or can lead to podocyte proliferation as a response to the injury. If the proliferation rate is low, you get what's known as mesangial sclerosis, as what we see in diffuse mesangial sclerosis or DMS, or if it's high, you get what we see in collapsing glomerulopathy. So at the end of the day, it's a podocytopathy. So focal segmental glomerulosclerosis. Now, this is one, I think, of the most difficult problems we have in biopsy and in clinical settings. Let's start by its definition. Segmental sclerosis is basically obliteration of the capillary lumen by increased extracellular matrix. And it involves part of the glomerulus. This is why it's segmental. It can have with or without hyalinosis, with or without foam cells, which are histocytes or macrophages, and with or without overlying epithelial cell hyperplasia. So you have an area of collapse where you don't see the capillary lumen anymore. You can have some hyalinosis, and you can have overlying epithelial cell hyperplasia. This segmental sclerotic lesion has only a small volume, usually 12% of the entire glomerular volume, so it can be easily missed on a single section. And this is the utmost importance of serialing, what we've discussed last time, that we must have at least 20 serial sections to make sure that we did not miss a segmental lesion. And the term focal denotes a heterogeneous involvement of the glomeruli, as we said, less than 50%. This is the classical definition of FSGS. However, FSGS is not always sclerosis. So sometimes you get it proliferating and sometimes you get a lot of cellularity. And serial morphologic analysis in the various forms of FSGS shows that the sclerotic lesion actually involves the great majority of the glomeruli, revealing that FSGS is not as focal as the name implies. So yes, we call it a focal segmental lesion, but maybe we don't work up our biopsies that properly. Hence, the most important point in diagnosis of this disease is sampling issues. You have to have a very adequate sample if you want to know if your patient has FSGS or not. As I mentioned before, we have a little evidence base for what is considered an adequate biopsy or an optimal laboratory procedure, but we do our best. We know that early FSGS are preferred juxtamedullary glomeruli. We know we need a lot of serials. We know we need at least more than 20 gloms in the biopsy so that we can confidently exclude that we don't have an FSGS lesions. As I said, the diagnostic lesion may be missed by sampling artifact, affected glomeruli not present in the section, and a segmental lesion not present in the plane of the section. Now, this is a bit of a physics because 3D morphometry, when it involves only 12%, so in the plane of the section you're taking, it might not be present, although the glomerulus have FSGS. So it can be a bit tricky in its diagnosis. How does it develop? How does someone develops FSGS? Now, a normal glomerulus with intact food processes, as you can see that the podocytes are attached to the glomerular basement membrane just with their food processes. This is not a secure attachment to the glomerular basement membranes. So it can happen that these food processes can detach, fall into the urine upon mild podocyte injury. But then podocytes are post-mitotic cells which can regenerate up to a certain extent, and they can regenerate themselves and new podocytes with new food processes show up. However, if the extent of injury is too much for the podocyte capacity to repair, then the food process effacement occurs. Probably food process effacement is a form of a protection of the podocyte against falling down. So instead of just being slightly anchored to the glomerular basement membranes, they efface their food processes and lie along the glomerular basement membranes to prevent their loss. But again, with continuous injury, the podocytes start to detach, fall down, you start to have capillary collapse and regular repair process. In place of the shedded podocytes, you get segmental sclerosis with podocyte loss, and then this is what we see in the light microscopy as focal segmental glomerulosclerosis. So this is how we develop FSGS, and this is what goes with the concept of podocytopathies. So if either the injury can stop, where you can get some few little podocytes or podocytopenia while they are detaching and repairing themselves, or the process can stop at the level of effacement as we see in minimal change, or it can develop into a full-blown segmental sclerosis. The most important point is that what we call focal segmental glomerulosclerosis is not a disease. It's a clinical-pathological. The etiologies are diverse and multiple. We have idiopathic FSGS, immunological, virus-associated as HIV, parvo-19. We have drug toxicity. We have familial and hereditary forms. We have genetic disease. We have the mechanical injury, and so on. So this is not a single disease, and it's not a single basically a pattern with a lot of clinical pathological differential diagnosis. The morphology, which we see in the biopsy, can to some extent reflect the etiology and maybe predict the prognosis of FSGS. And towards this end, in 2004, Columbia classification for a morphological classification of FSGS have showed up. Again, this is a morphological classification, defining mainly 5 variants of FSGS, 5 morphological patterns of FSGS. not otherwise specified, where you get at least one glomerulus with segmental increase in matrix, perihilar variant, one glomerulus with perihilar hyalinosis, with or without sclerosis, and more than 50% of the glomeruli affected. This is the only variant which requires that more than 50% of the glomeruli you see are affected. Other than that, all variants are diagnosed by a single glomerulus. So if I have a single glomerulus with a segmental or global collapse, then this is a collapsing variant. And if I have a single glomerulus with a tip variant, then this is a tip variant and the cellular. Let's take a look at them. This is how they look. This is the glomerulus again. This is the hilum of the glomerulus. So this is the perihilar. This is the tip, which has to be correspondent to the hilum on the other side. This is collapsing, where you get florid epithelial cell hyperplasia, and this is the cellular type. Any one of these can end into what we call not otherwise specified or NOS variant, meaning we couldn't specify which one of the morphological forms was this FSGS. Let's start with the perihilar variant. Now, this is classic perihilar variant.
Dr. Wesam, just a question here. Does it mean that none otherwise specified is the end of any spectrum, or it is a special one?
No, it's not special.
So it is not the fifth morphological pattern of FSGS.
It's the fifth morphological pattern, but these are all morphological. But yes,
I know.
If I can,
it is not a separate entity. It is the result of any of the previous patterns, the four patterns you mentioned.
It means basically, if I can't classify the FSGS I'm seeing into any one of these four, then it's then it's NOS.
And it's not a separate entity.
No.
Okay.
But actually, I don't see any one of them as they're just morphology. They're just the way the FSGS looks in the biopsy. I'm going to say their correlations. Okay, so the perihilar variant, no, it's the least specific entity of them, if this answers your question. This is the least specific morphological variant, definitely. So this sclerosis and hyalinosis adjacent to the vascular pole. So this is the vascular pole of the glomerulus. This is the tip of the glomerulus, the tubular pole. So we have here tubules and we have here arterioles or the hilum. And so perihilar variant is here. So you have it adjacent to the vascular pole. This type is typically seen in secondary FSGS, maladaptive forms, obesity, hypertension, reduced renal mass, but it can also be primary and it can be in the genetic forms. It basically reflects an adaptive response, and non-sclerosed glomeruli, they're typically enlarged glomerulomegaly, but be careful of this because glomerulomegaly is not a very reliable measure on just a core biopsy by light microscopy. You need to see it in so many serial sections to really make sure that the glomeruli are enlarged. And these patients are more likely to present with subnephrotic proteinuria and normal serum albumin level. Again, this is perihilar. So this is what we call segmental. This is a normal glomerulus, and you have an area which is sclerosed, hyalinosed, obliterated. You don't see open capillary lumina. Compare this to this. This is open capillary lumina. This is obliterated, and this is your arteriole. Again, perihilar. This is trichrome. This is again a segmental lesion. Here is the glomerulus, and here is the sclerosis. The second variant is the tip variant. This time we have the lesion at the tubular pole, which is opposite of the hilum or opposite of the vascular pole. That means that you have to see the vascular pole in the section before you diagnose this as a tip variant. This variant is mainly non-sclerotic. It presents more with hypercellularity, with a lot of foam cells, but eventually you get some hyalinosis and some sclerosis. The problem with this variant as well, it causes herniation. You get herniation of the glomerulus into the tubular pole, as you can see in this picture. And as I said, you get hypercellularity. Here you don't have any frank sclerosis, but you get a lot of foam cells. Tip variants can be non-specific because you can see them in all conditions with heavy proteinuria, like in membranous, like in diabetes, but in that scenario, you have other pathology going on in the glomerulus. How big shall we consider a tip variant? Up to 25% of the circumference of the glomerulus, you can still call it a tip, and you don't move into NOS yet. This is classic tip variant. Again, this is the vascular pole of the glomerulus. This is the tubular pole. You can see the glomerulus herniating into the tubular pole. You have here a lot of histiocytes and early sclerosis. Again, here, this is the vascular pole. This is the tubular pole. You get a lot of histiocytes here and proliferation and no sclerosis, but still this is FSGS, like the glomerulus. And you see two adjacent glomeruli, and both of them has FSGS, referring to the focal lesion. Now, here we started to have sclerosis and very few histiocytes and slight overlying epithelial cell hyperplasia, and it involves up to 25% of the glomerulus. This is still a tip lesion. Again, here, a completely sclerosed tip lesion. And here, this is a tip lesion with hyalinosis. You agree? You agree? This is the vascular pole. This is the tubular pole. And you have hyalinosis here. So this is tip variant. Okay, it's not tip variant because this is the rest of the arteriole. These are only hyalinotic nodules. This is perihilar variant. I just want to tell you that it's not always that easy to differentiate between them because, again, it depends on the plane of the cut, of the suction, and on the serial.
Dr. Wesam, just I have in the chat Dr. شفيق أحمد العماد رئيس اسم الكلى في صنعاء. طبعا احنا طبعا معانا ناس من اليمن
يعني منورنا.
لو في أي سؤال أو أي مداخلة احنا بنرحب بك يا دكتور شفيق.
The third variant is what we call collapsing variant. Now, this is where you get segmental or global collapse and overlying epithelial hypertrophy and hyperplasia with variable degrees. Look at this glomerulus. This glomerulus is not a chronic glomerulus. The Bowman's capsule is fine. The glomerular tuft is collapsed, so it's not shrunken, and you have minimal epithelial cell hyperplasia. Again here, this is a collapsed glomerulus. Why do I say collapsed? Because there you have an empty Bowman space here. It should be up to here. And you have epithelial cell hyperplasia. The hyperplasia can be florid, and it may fill all the urinary space resembling a crescent, as you can see here, and usually have these micro absorption droplets within the podocytes. The also podocytes tend to look enlarged and a bit aberrant within this variance.
Dr. Wesam, so if I don't have these droplets, why I'm not saying it's a shrunken tuft?
It's a shrunken tuft. Just look at the tuft.
Yes.
This is collapsed. It's not shrunken.
Not this slide, the slide before.
Why am I not saying this one is a shrunken tuft?
Not this, the previous, yes. Yes, all these two slides. Why I'm saying it's shrunken tuft?
Because you can see that you still have more or less the glomerulus is intact and it's collapsed. And you have usually with shrunken tufts, you don't get any form of epithelial cell hyperplasia.
Okay. Okay.
But it's difficult. It's not sometimes you don't know whether it is a shrunken tuft or it's a collapsing FSGS. And as I'm going to show you, you also cannot know whether this is a true crescent or a pseudo crescent. It's not that straightforward. This is the classic picture, but you don't always get this. You don't get it this way. The important thing is that collapsing variant is primary FSGS, but it's also secondary to viruses like HIV, parvo, SV40, CMV can cause it, Epstein-Barr can cause it. Drugs, as pamidronate and interferon, we know that interferon can cause collapsing glomerulopathy. But the important point is that remember that you can get also collapsing glomerulopathy with vaso-occlusive disease. Atheroemboli would give you the same picture, CNI nephrotoxicity, and in chronic transplant changes, you can also get a collapsing glomerulopathy. Now look at this. This is, can you really see the glomerulus? This is all what is left of the glomerulus. And all of this is the epithelial cell hyperplasia with so many microabsorption droplets. This is a straightforward collapsing glomerulopathy. But look at this one. Is this a crescent or is it a collapsing FSGS? It's really difficult to say. However, these are only podocytes.
The Bowman space is intact, Dr. Wesam. If the Bowman
I think
space,
it's a collapsing epithelium.
You can get a crescent with an intact Bowman space. It does not rupture the Bowman space, no.
Okay.
If it ruptured, usually the very aggressive ones are the ones which rupture the Bowman space, like in anti-GBM. But in other diseases, you have an intact Bowman's space. So these are mainly, all of them are podocytes, and you get almost a sclerosed glomerulus with collapsed segments. Look at this one. This is what you were saying. Is this a shrunken glomerulus or again it's a collapsing FSGS? Now this is where the interpretation part comes. This is the morphological pattern you have. But if you tell me that this patient is nephrotic and presenting with a rapid deterioration of renal function, then probably this is collapsing FSGS. Yes. So this is what we've been saying. This is the pattern I have. It's not going to be a disease unless you tell me what the patient has. And his immuno is negative, of course. Now look at this. This is again typical segmental collapse. And you get all of these proliferating podocytes here and there. And collapse, and again, these very few microabsorption droplets. Compare it with this glomerulus. Now you have hypercellularity, and here you have a crescent. And this is a true crescent because this one has fibroblasts and has inflammation, and it showed early necrosis in the cereals, and the glomerulus is inflamed. You can see that you have here lymphocytes compared to this one, where you cannot really see the lumina. It's not easy. It takes a lot of time. It puts us in a lot of diagnostic dilemma to figure out whether this patient has crescents or he has a collapsing form of FSGS. And look at this one, for example. This looks like a typical crescent. But again, this patient did have a collapsing FSGS. So within this entity, it's not always straightforward to know whether this is a true crescent or a pseudo crescent, and we rely on so many features, serial sections, our immuno, the clinical data, how do they look in all of the sections. But as I said, these ones do present a diagnostic dilemma.
I think a clinical, Dr. Wesam, clinical presentation is very important. So if I don't have nephrotic syndrome, nephrotic range proteinuria, it is difficult to accept collapse. What's your opinion about this point?
There are recent reports that collapsing FSGS can present with a subnephrotic range proteinuria, which is starting to cause a more diagnostic problem. The classic one is, of course, your typical nephrotic patient with the acute renal failure. This equals collapsing nephrotic syndrome. But there have been some reports of patients with collapsing FSGS presenting with a subnephrotic proteinuria. So yes, you can stop at certain level in these patients and say, I don't know if this is really a crescent or a pseudocrescent. The following variant is the cellular variant. Now, this is a variant with a question mark. This is where you get expansile segmental region rather than collapsing. So this time you also have a lot of cells, but the cells are intracapillary, not extracapillary, and the capillary is expanded. And usually these cells are macrophages and endothelial cells and foam cells. It's a very, very rare variant. So some questions that it exists, and some, and I'm convinced with this, thinks that this represents the early stage of FSGS, which we hardly catch on biopsies, as we think that NOS represents the last stage of FSGS, which we usually biopsy in. And probably the other variants are the one in between. Now, cellular, usually primary, but can be seen in secondary forms as well. And this is the typical cellular variant of FSGS. The important point is that to know that this variant is also a malignant variant. It's not such a benign variant with a benign course for the patients. These patients also behave aggressively. And the last one is what we call as not otherwise specified. That means it's not collapsing, it's not a tip variant, it's not perihilar. So if I can't classify the FSGS into any one of these morphological variants, then it's an NOS. This one usually represents advanced focal segmental glomerulosclerosis, and you get a combination between tip and perihilar lesion. That's the classic form, and it's the commonest form we see in the biopsy. So you can see here, you have perihilar and you have tip lesion. So this would be classified as NOS. Again, perihilar, it's almost involving up to 50% or up to 40% of the glomerulus. So this is again not otherwise specified or NOS. NOS again, you cannot really say where is the FSGS, is it perihilar, is it tip? And sometimes you cannot say because you don't see the vascular pole or the tubular pole within all the sections you have done. So it has to be classified as NOS as well. Immunohistochemistry. Now remember that immunohistochemistry has no role in FSGS. It doesn't diagnose FSGS. FSGS is a light microscopy diagnosis. You're not going to know if your patient has FSGS or not, except if we see it under light microscopy. Full stop. No other modality is going to help you. And that's why we insist on the adequacy of the specimen. So you cannot diagnose FSGS with immunohistochemistry or with fluorescence. I know that it's written in every single reference you study from that in FSGS, you get IgM, positive IgM and C3. But as we've discussed before, this is not a significant, these are no significant immune deposits. We have segmental sclerotic areas which stand for IgM, T1Q, and C3. Okay, this is macromolecular non-specific trapping of these antibodies, whether by immunohistochemistry or by immuno. Does that mean we don't do immuno? No, it's mandatory. Why? In order to recognize non-specific scarring, as in glomerulonephritis, as MGN, as in class 2 lupus, and as in IgA nephropathy. So when I have an FSGS in light microscopy, I don't know whether do I have an underlying glomerulonephritis with it or not if I don't do immuno. I can't just rely on what I see. Look at this glomerulus. It's all messed up. You have a segmental area of hyalinosis. You have a segmental area of sclerosis. You have epithelial cell hyperplasia, which could be a crescent. And you have the rest of the glomerulus also showing other things. Thickened basal membranes. Could be TMA, could be membranous, could be lupus, could be IgA, could be anything. So I shouldn't diagnose this glomerulus as an FSGS. This glomerulus needs immuno to know, is it just pure FSGS and it's a chronic glomerulus, or do we have an underlying glomerulonephritis with it? However, there have been recent articles saying that there is a clinical significance, not a diagnostic significance, for the presence of IgM and C3 glomerular deposition in primary focal segmental glomerulosclerosis. Now, this Chinese group have studied 106 patients with primary FSGS with their outcomes, and they have concluded that patients with primary FSGS who has IgM and C3 deposits show unfavorable therapeutic outcome and worse renal outcomes, which can indicate that IgM and C3 deposits might involve some form of disease progression. So again, they are not diagnostic, but there have been some reports saying that they could carry some clinical significance. And this might explain why in some FSGS we find IgM and C3, and in others they are not deposited. So you don't always even get it, this non-specific trapping. Not all the biopsy, irrelevant of the form or the morphologic variant of the FSGS. Some of them get the immune globulins, others don't. There has been an interesting, very recent study actually by Ingeberg from Rotterdam group in Netherlands, and they have looked at the glomerular C4D deposition in patients with FSGS, and they have concluded that C4D can precede the development of FSGS. I think this is an interesting study because it actually coincides with our own observation during routine work. So, and this is going to be my first but not last mentioning of C4D in native biopsies. I know you all know C4D in transplant, but this is, I'm going to show you that we do use C4D staining as well in the evaluation of native biopsies. So we're going to start by the FSGS. So this work group have stained renal biopsies for C4D, C1q, and NOS binding lectin, following the recent concept that complement could be playing a role in FSGS and that it could be a complement-mediated disease, or at least it's playing a role in it. So they stained biopsies from 40 patients with primary FSGS, 84 patients with minimal change disease, 10 healthy individuals. They also included 34 transplant biopsies from patients with known native primary FSGS. 18 of them showed recurrence, and they have measured the C4D deposits in the glomeruli of the Immunohistochemistry rat model of FSGS. Their results showed that they had a prevalence of C4D positive glomeruli, which was significantly higher among patients with FSGS, 73%, compared to minimal change 21%, and healthy individual 10%. Moreover, they showed that segmental sclerosis was absent in up to 42% of the C4D positive glomeruli, and they have shown that in the rats, that the C4D deposit coincided with the appearance of microalbuminuria before even the sclerotic lesion was there. As per the C1q, glomerular C1q was also significantly more prevalent in FSGS compared to minimal change. And they've seen that C4D deposits in the transplant biopsies was more prevalent in recurrent FSGS, 72%, before the development of sclerotic lesions, compared to controlled transplant samples, which was 27%. And they found no role in NOS binding lectin, which was infrequently observed. This is so you can see this is more or less a normal glomerulus, only with slight podocyte irritation, and you get the segmental C4D deposits. And here within the segmental sclerosis, you get the segmental C4D deposits. As I said, this is interesting because we've been seeing this for years. We know that C4D deposits within sclerotic area. I usually tell my fellows, they come to saying that this patient has immune complexes because his C4D is positive, but C4D does deposit within sclerotic areas, and maybe it does play a role. And it's helpful to know that it can precede the development of the sclerotic lesion itself. In all cases, this needs more validation, but I always find it a very helpful diagnostic tool actually in routine practice. At least it can alert you that you might have an FSGS lesion somewhere in the biopsy. EM. Now, EM can help in telling you whether this is a primary form of FSGS or a secondary form of FSGS. Because as we've been saying, the primary FSGS is a podocytopathy. So only primary FSGS is a podocytopathy, and you will get exactly the same picture like minimal change. That's why I say if you don't know if the patient is minimal change on FSGS, EM is not going to tell you. It's going to tell you if the patient has something else other than these two diseases, but it's not going to differentiate between them. So primary FSGS, you get diffuse podocyte effacement. If you're lucky, or if it's an advanced case, you're going to see the sclerotic lesion within the glomerulus. You can see the glomerular collapse and the complete loss of overlying podocytes, not even any form of foot processes. morphology has any relation to outcome. Yeah, there have been some old studies when the Columbia classification came out, but till now, their results are valid. They had examined 87 nephrotic adults with primary FSGS, up to 10-year renal survival. And they've shown that the best renal survival was related to TIP, the worst was related to collapsing, and FSGS was something, the NOS was something in between, probably because we don't know which variant was it in the beginning. However, in this study, they also concluded that prognosis dependent if the patient was steroid sensitive or responded to treatment in general and entered remission regardless of the pathology which was noted. And so response to treatment cannot be predicted on the basis of histology alone, and that the response of steroid therapy is the best indicator of long-term outcome, meaning that you always have to try, even if you know that they have a prognosis. But a more recent study with a clinical trial in 2013, these have done on children, and they have looked at 138 steroid-resistant children and adults, 2 to 40 years, classified using Columbia scheming. So they had 70% NOS form, because usually biopsies come late. They had 10% collapsing, 10% TIP, and 7% Perihilar. All of them were treated with cyclosporin or MMF plus dexamethasone. After 3 years follow-up, they had end-stage renal disease in up to 50% with the collapsing variant, 20% only in the NOS, and 7% only with TIP variant. Regardless of the morphology, the way we have to look at FSGS is through its subclasses. Our target is always to know whether this is a primary form of FSGS, is this a genetic form of FSGS, or is this a secondary form of FSGS? And their differentiation requires a very thorough and proper clinical pathological approach, and it shouldn't be taken lightly. If we came to correlate the clinical pathological correlations with the variants, with the morphological variants, then we come again to the same results of the older studies. That NOS, FSGS, this is the most common variant because it's the most common morphology we see on biopsies, and it is equally distributed among primary and secondary forms. So if you get an FSGS with not otherwise specified, your patient can be anything, primary or secondary. Perihilar FSGS. Yes, it's more usual in the maladaptive forms. It's usually more pro-secondary, but can also occur in primary FSGS. We see it in children with full-blown nephrotic syndromes, and it can also occur in genetic FSGS. These type of variants have low remission rate and have an intermediate renal survival. So not because that they are secondary, it means that your patient is going to do well. TIP lesion, cellular, and collapsing variants usually share the presenting features of heavy proteinuria and the nephrotic syndrome. As I have just said, they may also present with subnephrotic range proteinuria. TIP variant usually presents with a full-blown nephrotic syndrome in older adults, has a strong predilection for whites, has a very high remission rate, very good response, and is considered overall the best prognosis in all of them. Collapsing FSGS, on the other hand, again, patients will present with a severe nephrotic syndrome, but also rapid progression to end-stage renal disease. And it has a very strong predilection in patients with African heritage, and it has the worst prognosis and the most malignant course of all of them. Patients end up in end-stage renal disease within 6 months. This variant, I think, by time, is going to be removed out of the FSGS because it really has a completely different clinical course and morphological characteristics from the other FSGS variants. Some believe that it's a different entity altogether, and I'm with this belief. I think this is a separate disease. We have FSGS, which is a very low incidence. As I said, some debate whether this is a variant which exists, and prognosis is intermediate between collapsing and TIP variant. So morphological variants are important because they can give you an idea what you're dealing with in relation possibly to the form of the FSGS, and it can tell you the prognosis, the possible prognosis of your patient. So it's very important to classify. I'm going just to spend 1 minute on genetic FSGS because this is the most recent entity. It's a lot of significance, and it's very important for us to consider. You have always to remember that FSGS is not only primary and secondary, it's primary, genetic, and secondary. And the genetic causes of FSGS may present as sporadic cases or familial diseases. So not every patient with genetic FSGS is going to come to you with a family history. And the mode of inheritance covers all types of genetic inheritance, autosomal dominant, recessive, X-linked, or it can even be mitochondrial inheritance patterns. The age of onset of genetic FSGS is usually early childhood, since it's FSGS, but we're learning and we're seeing through the recent past years that additional mutations which are associated with FSGS are identified in adult onset genetic FSGS, and they're getting more and more, and they're assuming increased significance. So yes, a genetic FSGS can occur in adults, and it can be sporadic. It doesn't have to have a family history. Genetic FSGS can also be limited to the kidney only. So the problem is only related to the kidney, or can be part of a broader syndrome with extrarenal involvement. Genetic FSGS is typically resistant to corticosteroids. So these patients are not going to benefit from immunosuppression. They might get worse. Some of them respond to calcineurin inhibitors. It can be effective in few patients have been reported, but probably this is due to the effect of the cyclosporin on the podocyte cytoskeleton, not to the fact that it has an immune underlying mechanism. The best known of the genes of these forms of FSGS are the G1 and G2 polymorphisms in the ApoL1 gene, patient of African ancestry, and these patients present with, if they have a mild affection, they're going to get end-stage kidney disease only with hypertension. A moderate genetic affection, they're going to present with steroid-resistant nephrotic syndrome, and you get your classic form of FSGS. But some of them, and these are common ones, present with severe forms and get rapidly progressive renal failure nephrotic syndrome with a collapsing variant of FSGS. And maybe that's why the reason that collapsing have been described early on, that it's common in patients with African ancestry, especially West Africans. I'm not going to go through this. I'm just showing you the extent of genetic mutations you can get either in limited forms or within all types of syndromes which can affect your patient. Of course, when, how, and for which patients you do genetic analysis is beyond the scope of this lecture. And
Dr. Wesam, since many months, we had Professor Al-Qousi from UK, and he commented on one of our cases, FSGS, that in UK, they did genetic testing for FSGS. And a few months later, we meet Dr. Ihab Shaheen, who is pediatric nephrologist, and I reviewed the issue of genetics by myself. The conclusion that I reached, it is if the nephrotic syndrome or FSGS occurs before the age of 1 year, it's better to do genetic testing. If it's steroid resistant in children, in adults, or there is, as you mentioned, syndromic nephrotic syndrome. Syndromic means extrarenal affection. And probably after listening to your presentation, I can add, if we are in the African ancestry or African American, it's better to test for apolipoprotein gene because of its link. So this is what we have nowadays. In the future, with the availability of genetic testing, it may be crucial to test for the genetics for FSGS for all cases.
This is what we're hoping for, and you're absolutely right. Actually, the chances of getting a proper genetic mapping decreases with age. Yes. So in early childhood and within the first couple of years, you get a 60% chance that you will identify the gene. And then it decreases to 40% up to adolescence. And in adolescence, they had only been able to identify it within 10 to 20% of the patients. That means you completely lose it in the adults. And the reason I've shown these tables is that, yes, it's horribly expensive now. It's not widely accepted, but maybe not in our lifetime, maybe in your lifetime, in the young ones, then you're going to do it as a routine. And as you order and right now a proteinuria test, you're going to order also the genetic testing. That's the future of the medicine. This is what's going to happen. You need to integrate it from now, and you need to know that this is what you will have to do later on for your patients.
Let me to stress on another point rather than away from the genetic testing, which is the etiology. We should evaluate the patient thoroughly, looking at because we may have collapsing FSGS because of hepatitis B, HIV. Yes. So we should think of the etiology, because if I have collapsing FSGS due to hepatitis B, the treatment is not immunosuppressive drugs. It will be anti-hepatitis B drugs like entecavir or something like that. And there are some case reports about this point. And I want to ask you about obesity-related glomerulopathy, because I read since a long time the density and the volume and the lower density of the glomeruli and the bigger volume of the glomeruli this is one of the criteria of obesity-related glomerulopathy. So I want to hear from you some points about this issue.
It follows the same, this is what we consider a mechanical form of injury for FSGS. And usually these patients are the typical patients which are going to present with the Perihilar variant.
Okay. So
and enlarged glomeruli, mainly the hyperfiltration, because as you said, due to the decrease in the glomerular density.
And the clinical rounds, usually we ask it about the difference between primary FSGS or secondary FSGS in obese person. Is it primary or secondary? Immunofluorescence, as you mentioned, have nothing to differentiate. EM may help if it is universal, effacement of food process.
Actually, this is.
Yeah.
Yes.
And we may, I want to ask you about the diameter of glomerulus. Do you measure it, glomerulomegaly or glomerular hypertrophy?
No, because you need to measure it in, I think, more than 50 serial sections.
Yes.
It's impossible, because you never get enough tissue. You need to measure it in every serial section in more than 50 serial sections. We use a more of a crude way.
Okay.
We know that a normal glomerulus on our high power field should not involve more than 50% of my high power field under the microscope. If the glomerulus involves more than the 50% of the field, if I go on high power and all what I see is the capillary and I can't see the periphery of the glomerulus, this is definitely an enlarged glomerulus.
The last point, in just a commentary, FSGS is misnomer because it is not focal. If we do electron microscope, we find effacement in more than 80% of the glomerular capillaries. So it is, as you mentioned in your presentation, AMMA doesn't differentiate between minimal change and FSGS. So this is why some authors consider FSGS as misnomer. It is diffuse effacement of food process.
It must be changed because you see that the variants are completely different.
Yes.
Different prognosis, different presentation, different etiologies, and it's one of the diseases which should be looked at as we looked at other diseases and we managed to change them. So I think we're on the way. Following what we've been discussing and your comments, Dr. Hussein, this is just a case scenario. I'm not going to, but I just want to show you applying what we've been discussing. This is a 30-year-old male presented with 1 month severe headache, found to be hypertensive. His blood pressure was 220/120, and his serum creat was 4 milligram. Urine albumin 2+, sugar nil, white blood cells, a slightly active urinary sediment, anemic, white blood cells normal, platelets normal, immunology and virology completely free. Sonography, right kidneys 12.6, left 12, no renal artery stenosis. And in biopsy, he showed advanced FSGS, global glomerulosclerosis 60%, IFTA 70%, and his immuno showed C3 deposits in scarred areas. My question is this an FSGS patient? I would like as much of you, please, to participate in this question. This is extremely important. Again, this is a 30-year-old male who presented with only 1 month history of severe headache. He got into uncontrolled hypertension, or his hypertension is 220/120, and a serum creat of 4. He has moderate albuminuria. I don't know how much is it. And you always like to put these pluses to me, which means nothing. And his biopsy showed exactly this: advanced focal segmental glomerulosclerosis, global glomerulosclerosis 60%, and if interstitial fibrosis and tubular atrophy 70%. Almost an end-stage kidney.
Do we have any data about his
areas? Yes.
Do we have any data about his serum albumin or his general status, like if there was edema, lower limb, or puffy face?
No. Thank you. This data makes a hell of a difference. If we know that if we know his serum albumin, if we know if he is, he probably has some lower limb edema, but his serum albumin is very important.
Okay, based on these data, regarding that, I don't know what his serum albumin is.
So his biopsy has FSGS.
Okay.
Okay.
Based on these data, I don't know what his serum albumin is. I don't know if he had severe edema or puffy face. One of the differential diagnoses would be FSGS. It could be also an MPGN pattern.
Dr. Shafiq Al-Ahmad from UK, he is in UK, bought an answer hypertensive nephrosclerosis.
Okay.
And another doctor, the same hypertensive nephrosclerosis, and maybe FSGS or late form of MPGN or anything.
MPGN, yes, of C3 glomerulonephritis. That's what I want to say.
No. Be careful. Be careful of how you interpret it. Just a second, Dr. Hussein. These are C3 deposits in scarred areas, in the segmental sclerosis. They're not in the mesangial, they are not in the glomerular basement membrane. There is no place for MPGN at all. No place for MPGN. And neither the pattern was an MPGN, nor the immuno, even if it was too advanced to recognize a pattern. The immuno was just C3. Read the reports carefully. Read what's written in the reports. We've just said more than once, C3 can deposit only in sclerotic areas. This is not a significant C3 at all. And you're right, it can be anything. And this is my point exactly. This patient can be anything. Can be hypertensive nephrosclerosis, can be a primary FSGS, might have a hereditary disease, might have basically a tubulointerstitial disease. He can be anything. Although his FSGS looked like a tip variant, but he still can be anything. Differentiation requires clinical-pathological approach, again, to know what's the origin of this patient. How can pathology help you? If I want to know that if this patient is primary or maladaptive, as you said, in hypertensive nephrosclerosis. Okay, primary FSGS, and as the first question which was asked by Mohammed, what's his serum albumin? Primary FSGS presents like minimal change, abrupt onset of nephrotic syndrome, not nephrotic range proteinuria. And of course, you know better than me that there is a difference. In this scenario, kidney biopsy is often done early in the course and generally shows a relatively well-preserved parenchyma with few glomeruli featuring the characteristic FSGS lesion. So here you go. You have these nice glomeruli with this nice FSGS lesion and a very nice renal parenchyma, minimal interstitial fibrosis, no vascular affection. This is 99% primary FSGS. No, there is no, this is a very typical and classic case. I don't need to wonder if this patient is secondary or not. Okay? On the other hand, maladaptive or hypertensive FSGS often present with a progressive proteinuria, and the kidney biopsy, whether it reaches a nephrotic range or not, it can, of course, present with heavy proteinuria. And the kidney biopsy is done later in the course. So you get varying degrees of parenchymal scarring, which are often associated with maladaptive FSGS, like our patient. So if I have these two scenarios, yes, I can tell you that this is probably, that this is primary FSGS and that this is secondary FSGS. And this is what I've referred to about that we can suggest from the overall pathology we're seeing what is the form. However, if we get into an advanced stage, I cannot differentiate between primary and maladaptive FSGS on the base on light microscopy. They are indistinguishable. But then a good clinical history, whether the patient has nephrotic syndrome or not, whether his serum albumin is down or not, whether he is still massively proteinuric with this extent of glomerulosclerosis, all of this goes with primary FSGS, because it's really strange that in podocytopathies, even when patients with reach up to 75% glomerulosclerosis, they're still markedly proteinuric, versus the secondary forms where proteinuria, or in any other glomerulonephritis, whenever you approach global glomerulosclerosis, your proteinuria start to decrease, except in primary podocytopathies. Electron microscopy can help in primary and secondary forms, because primary is diffuse podocyte effacement, while in secondary, you get a segmental podocyte effacement. But if we followed our patient scenario, it's not going to help me to tell me whether this patient is genetic or not, because this patient could be genetic, and he could have been complicated with the hypertension because he was almost end-stage renal disease. It does not have to be that the hypertension was pre-existing. So why is it not going to tell me if it's genetic or not? Because genetic FSGS can present with diffuse effacement and genetic effacement. This is a very nice example I found in the literature. And look at this. Now, these two EM biopsies are from two siblings who both have compound heterozygotes for the NPHS2 mutation, which is a very known mutation which causes FSGS. Now, these two pictures are from the 63-year-old brother with a serum creat of 1.1, proteinuria 6.6, and I think I can't see the serum albumin, I think it's 3, okay? And you can see, so this was the time of his presentation of the genetic FSGS. You can see that he has diffuse podocyte effacement. These are the capillary loops, and you cannot see any food processes. So all through his podocytes were effaced. Now these ones are from his sister. His sister is 47-year-old. She has a serum creat 0.9, proteinuria 2.5 grams, which is non-nephrotic, and a serum albumin, I can't see because I have, hold on, 4. And her EM, as you can see, shows segmental food process effacement. You can see the podocytes here. This is, you can see the food processes here, and you can see here that you have diffuse food processes. So this is, to you, is genetic FSGS. You can see how heterogeneous, how variable it is, both in morphology and in clinical. But more important is that we don't only have to differentiate between the primary, secondary, and genetic form of FSGS, which is sometimes difficult, but we have to differentiate what we call FSGS from non-specific focal global glomerulosclerosis, which is seen in any ischemic glomerulus on its way to global glomerulosclerosis, and from focal segmental scarring, which occurs post-inflammatory and necrotizing lesions, which can occur in any glomerulonephritis. So look at here. This is a focal necrosis. This is segmental necrosis with proliferation in a lupus patient. This lesion is going to end in this, typically an FSGS lesion. So this cannot be called FSGS. It's not even secondary focal segmental. This is not FSGS at all. This is just simply secondary segmental scarring, post-inflammatory. This is a very important differentiation you have always to remember. So you don't get a lupus patient and you get a biopsy with FSGS and then you decide that this patient is FSGS. She is not FSGS. Okay? Any necrotizing or proliferative lesion will heal in segmental sclerosis. You have to differentiate between FSGS, which occurs in any glomerulonephritis or in any glomerular affection, whether it's a TMA, whether it's a membranous, whether it's an MPGN, you're going to end up with having segmental sclerosis, like these glomeruli in these membranous patients. So this is not FSGS, this is membranous with a secondary FSGS. That does not mean that the patient has two diseases. No, it means that the FSGS is simply the scarring of the glomerulus, because I get asked this a lot. So does the patient have membranous or FSGS? No, the patient has membranous. FSGS, if it's not written alone in the diagnostic line, means only non-specific scarring of the glomerulus. And this is not FSGS, because we get this a lot. Look at this glomerulus. You have sclerosis almost in 80% of the tuft. It does not even follow the definition of FSGS. This is almost global glomerulosclerosis. This is simply a glomerulus on its way to be globally sclerosed. But in some sections, there were still some patent capillary loops. And so I get a diagnosis of an FSGS. No, this is not FSGS. And this should not be called FSGS. This is global sclerosis of the glomeruli. Be careful, because FSGS is an aggressive disease. It's an ugly disease. So not any FSGS you see on biopsy is an FSGS. Again, this is not FSGS. Yes, you have segmental sclerosis of the glomerulus, but look at the glomerulus. The glomerulus is chronic, ischemic, have a thickened Bowman's capsule, it's shrunken, and it has this segmental sclerosis. Of course, it has segmental scarring, of course. It's a glomerulus on its way, again, to global sclerosis. And you have beside it extensive tubulointerstitial disease. These are only secondary changes to this tubulointerstitial disease. Again, I get a diagnostic line of an FSGS and chronic tubulointerstitial nephritis. What does that mean? And then the patient receives steroids. This is non-specific. And you do have focal global glomerulosclerosis. These glomeruli we've just seen are going to end up like this nice glomerulus. It's not obsolescent yet. You still have some capillary loops apparent, but it's globally sclerosed. Can you really tell anything of this glomerulus? Absolutely nothing. Look at the blood vessels. Look at the interstitium and the tubulointerstitium. So this is FGGS. Was it before FSGS? Maybe. Was it a membranous? Who knows? Was it an IgE nephropathy? A possibility. But it's an FGGS. This is a focal global glomerulosclerosis. So these entities are extremely important. They are more important than the FSGS itself, because these are the ones which we daily see in our biopsies. So yes, FSGS is a very common glomerulopathy, but it's more common in pathological diagnoses because most of them are non-specific. And it's your role. You need to understand the pathology report properly. You have the patient in front of you. You know the clinical data of the patient. You know the history. Read the report well when you get an FSGS before you decide to prescribe steroids. Please know what you have. So to sum up, how can we add up all what we've been discussing? If I want to try to reach a conclusion, whether my patient has a primary FSGS, a genetic FSGS, a maladaptive FSGS, or a focal global glomerulosclerosis, what do we see? In primary FSGS, clinical is that the patient has nephrotic syndrome. Full stop. Full stop. I don't want any one of you, to consider ever that an FSGS lesion could be primary. if your patient doesn't have a nephrotic syndrome. This is end of story. In light microscopy, we're going usually to see only FSGS, often no other damage unless late in disease course. This, of course, can happen. And it's not common to see enlarged glomeruli. And by electron microscopy, you get diffuse foot process effacement. In this category of patients, you usually don't get to the stage of EM. As I said, a nephrotic syndrome and FSGS is enough. In genetic, these patients, nephrotic syndromes are common in childhood, but are less common in adults. So an adult with genetic FSGS is not common to come presenting with a full-blown nephrotic syndrome, rather could be subnephrotic range or a nephrotic range proteinuria. Again, in the light microscopy, we're going only to see FSGS. It's common in adult, and if it's adult, we're also going to see global sclerosis. We don't see it in children, but we see it more in adult. So you get some segmentally sclerosed glomeruli, some globally sclerosed glomeruli. EM, unfortunately, is not going to help. It can be diffuse or segmental. Genetic FSGS comes by exclusion. Secondary is where you can get, again, a nephrotic or non-subnephrotic range proteinuria, no nephrotic syndrome. No nephrotic syndrome. You get light microscopy, FSGS, often perihilar. Often we get other signs of scarring, thickened blood vessels, markedly fibrosed tubulointerstitium, and we also get glomerulomegaly. It's common. It's common to see enlarged glomeruli, and by EM, you're going to get segmental foot processes. For focal global glomerulosclerosis, this is basically what you get, and this is the commonest, by the way, we see in hypertensive glomerulopathy. You don't always get the FSGS lesions. Patients present with variable proteinuria, usually subnephrotic, but sometimes all what you can see in the biopsy are the focal global glomerulosclerosed glomeruli, and you don't get the FSGS. So yes, we can get to a conclusion together. If you provide proper clinical data, and if we examine the pathology properly, then we can guide both of us and get to an idea what our patients have. Importantly, a misclassification may lead to inappropriate and potentially harmful therapy. Primary FSGS, by the way, can occur in a morbidly obese individual. So not every obese individual has a secondary FSGS. Physicians may be reluctant to prescribe corticosteroids because they are considered to be obesity-related FSGS. Now you need to do EM for these patients, especially if they have a full-blown nephrotic syndrome. Conversely, an adult patient with a sporadic and unrecognized genetic form of FSGS and without a family history or clinical evidence of secondary FSGS may be exposed to a long course of steroids and or CNI in the belief that the underlying lesion is primary when he is genetic and he's being steroid resistant, and you complicate the patient more in your fashion. Of course, transplant is very important because this influences transplant decisions, as we see every day, because only primary FSGS so far can recur in transplant. So go the extra mile in differentiating what exactly the focal segmental glomerulosclerosis you have in the pathology report means for your patient. And as I said, it's beyond our scope to consider which one to do genetic testing. But if you have, in all the other scenarios we've described, I would recommend that you read this paper. This is an excellent review by Glusek, and it sums up most of what we've discussed in this presentation. FSGS is a spectrum of podocytopathies. It's not a single disease. It's not just sclerosis. It has active lesions. Patients can get into renal failure, can be more aggressive than others. It involves activation, proliferation, dedifferentiation, migration, and matrix deposition. The pathologist should subclassify FSGS morphologically as well as do an effort to suggest the form based on both clinical and pathological data. I'll leave you with the fact that too often we talk about histological pattern of injuries, especially as FSGS, as if they were diseases, rather than the fact that they are only descriptions of kidney biopsy specimens at particular points in time. Thank you very much.
بشكرك شكرا جزيلا دكتور وسام، يعني حاجة ما شاء الله يعني. I want to just to add one point regarding the statement that you mentioned. Not every obese person who presents with nephrotic syndrome, this is a secondary FSGS. And if we have nephrotic range proteinuria, severe hypoalbuminemia, and the electron microscope shows diffuse effacement, and sometimes if we are in query state, we can prescribe immune suppression for this case, but for short period of time, because as you know, we don't like to give over prolonged course of steroid to obese person. Regarding global sclerosis, this is the brand of aging. So after the age of 20, we expected to find some global sclerosed glomeruli and nephrons. And there is, I think, an equation, age divided by 2 minus 10%. This equals the percentage of expected global sclerosed glomeruli. So at the end of this presentation, this is one of the very, very beneficial session. And I have no words to express my gratitude to Professor Wesam for this enthusiasm and meticulous efforts to make all of us understand the pathology of minimal chain and FSGS. Thank you very much. And inshallah, we'll meet in the next Friday, 1:30.
Inshallah. Thank
you,
Dr.
شاكرين جدا. شكرا جزيلا. والى هنا بننتهي حلقه اليوم، ونشوفكم ان شاء الله الجمعه الجايه الساعه 1:30. الى اللقاء، والسلام عليكم ورحمه الله وبركاته.